and thank you for logging in to this webinar. This is the APSS, the Asia Pacific Spine Society's second Advanced Spine webinar in 2025. And this afternoon's theme will be on adolescent idiopathic scoliosis, focusing on problem scenarios. We have online our chairman of the APSS online education committee, Dr. Shetty, and Dr. Vasavada. And we have a distinguished faculty joining us today: Dr. Jason Cheong from Hong Kong, Dr. Shinji Takahashi from Japan, Dr. Daisuke Sakai from Japan, and Dr. Dong-Gune Chang from Korea, as well as case presenters, Dr. Leok Lim from Singapore and Dr. Chris Chan from Malaysia. We have two excellent moderators, Dr. Cai Cao from China and Dr. Dong-Gune Chang will also be the moderators. All right. Without ado, I will hand over this program to the moderators who will start this session. Thank you.
Hello, everyone. I'm Dong-Gune Chang from Korea, and another moderator with me is Kai Cao.
Hi, I'm Kai Cao from China, and we'll be happy moderated with Dong-Gune Chang. So I think the first presenter is Dong-Gune Chang. His topic is current conception in choosing end vertebra in AIS. So please, Dong-Gune Chang.
Okay. Thank you, Thank you, Chairman. Today, I'll present on thoracic AIS, focusing on the distal fusion level. My disclosures. I'll present in the following orders: distal fusion level selection in thoracic AIS, the revised sub-classification considering touch vertebra concept, factors affecting the distal fusion level, especially focusing DVR and disc degeneration. Introduction. Fusion level selection is the most important single factors influencing surgical results after AI surgery. The goal of AI surgery is to maintain a balanced spine, and it has two conflicting goals: fusing as few motion segments as possible and correcting deformity as much as possible. There have been many advancements in the surgical techniques for AIS over the past 20 years. However, it has tended to increase the fusion level and more distal LIV over time. As you know, UIV is important for shoulder balance, and LIV is closely correlated with the long-term clinical outcomes. The second is about distal fusion level in single thoracic and double thoracic curve in AIS. Various AIS classifications have been introduced, and the most representative ones are King, Lanka, and sub-classification. However, these classifications are not completely independent and well interconnected each other. Sub-classification was first reported in 2027, divided into 4 curve types based on the size of thoracic and lumbar curves. This photo is my visit to TSRH 3 years ago, 2022 SRHM Fellowship. Sok's rule was displayed in the morning conference room to commemorate to Professor Suk's visit to TSRH. Professor Suk has published many papers on the fusion level for thoracic AIS, and we had been validating Professor Suk's papers. In 2022, we analyzed 65 thoracic AIS patients with a minimum 10-year follow-up and evaluate long-term radiology outcomes of selective thoracic fusion using rad rotation and DVR with PSF. The inclusion criteria were as follows. Finally, 65 patients were included and dividing into two groups, satisfactory and unsatisfactory group, according to the unsatisfactory results, including adding on or progression of LIV tilt and coronal balance. This case is a satisfactory group without any unsatisfactory results. This case is unsatisfactory group showing progression of LIV disc angle. In this study, there have been 13 cases of unsatisfactory results, and the overall incidence of unsatisfactory results was 20%. Among unsatisfactory results, 10 had an adding on, and 2 had a progression of coronal balance, and 1 had a progression of LIV tilt. In this study, selective thoracic fusion using rod rotation and DVR can achieve satisfactory deformity correction for thoracic AIS with long-term follow-up. However, progression of main thoracic and lumbar curve was closely correlated with the deterioration of LIV tilt and LIV disc angle, showing relatively short fusion and insufficient DVR. The third is about the revised subclassification, touchable tibia as ideal LIV. Recently, we studied touchable tibia as an ideal LIV in thoracic AIS. Touchable tibia concept is most separate vertebra between T12 and L5 touched by center sacral vertical line at any point. It is important to evaluate the benefit of touchable tibia concept among various classification systems. Therefore, this study was to evaluate the effectiveness of third modifier in Rankin classification and suggest a modified version of subclassifications using the touchable tibia concept. The inclusion criteria is thoracic AIS patients with a minimum 5-year follow-up. Finally, 141 patients were included and divided into 3 groups, matched, coded, and separate touchable tibia group. Matched touchable tibia group means touchable tibia is matched with LIV. In other words, touchable tibia is same the LIV. Coded touchable tibia means that touchable tibia is codal to LIV. And separate touchable tibia means touchable tibia is separate to LIV. Complications were included adding on phenomenon, coronal imbalance, and disjunctional kyphosis, and loss of distal motion segment. And CSV and LIV distance were also evaluated. In this study, matched touchable tibia was the most safe distal motion segment as one of the benefits of touchable tibia concepts in subclassifications. Regarding the complication, adding on phenomenon is predominant in coded touchable tibia group. Coronal imbalance was predominant in separate touchable tibia group. Therefore, touchable tibia is suggested to ideal LIV in subclassification. Why is the touchable tibia concept contribute to ideal LIV? This may be due to maintenance of CSVL LIV distance. In our study, Regarding the direction of DVR in subclassification, there was no significant difference of Nash and Moore scale between the three groups. Therefore, current version of DVR is no need to modify. In our study, regarding the we need to modify the traditional subclassification as follows. Therefore, touch vertebra is ideal LIV for thoracic AIS in Lanka or subclassifications. The fourth is about factors affecting for distal fusion level, especially focusing DVR and disc degeneration. The first is regarding the DVR. DVR is an innovative technical concept for correction of axial rotational deformity. DVR is also known to improve correction of both fused and unfused curve, reduce the fusion level, and be effective in rib hump reduction. Using the rotator into the pedicle screws, applying rotational force to the convex side. Intraoperative X-ray showing right thoracic curve of 62 degrees. When only large rotation was performed, it was corrected to 22 degrees. However, when additional DVR was added, it was further corrected to 16 degrees, showing additional correction of 6 degrees. The preoperative thoracic apical vertebral rotation of 19 degrees was improved to 10 degrees after DVR, showing 46% of rotational correction by DVR. In 2013, Professor held a hands-on workshop on DVR in 2013 IMAST. And we also reported the effect of DVR several times. Recently, we reported long-term follow-up rotational change using CT. This study was aimed to investigate long-term follow-up change in vertebral rotation using the CT. To accurately evaluate axial rotation, we evaluated the rotation angle to sacrum according to the Arrow-Dalbon method. This case showed rotational regression phenomenon in apical vertebra was already occurred within 1 year follow-up. In this study, DVR is effective maneuver for three-dimensional correction with long-term follow-up, showing rotational regression phenomenon apical vertebra and rotational maintenance phenomenon in distal end vertebra. The second is regarding the disc degeneration. Recently, we reported midterm outcomes of disc degeneration after DVR in AIS using MRI-based analysis. We speculated DVR can directly affect on the disc just above UIV and below LIV, lumbar scoliotic curve, disc, and unfused segments. 48 patients with 336 discs were included in this study, which were divided into two groups according to the disc degeneration. Disc degeneration was defined as the worst Fullman grade more than grade 4. For about 12-year follow-up, 42% of disc degeneration and 4% of modic change was observed respectively. Regarding the trend of disc degeneration and grading, just below LIV, L45, L5S1 showed the statistical significance between Fullman grade and disc degeneration. Pearson correlation analysis for disc degeneration showed significant negative correlation with preoperative thoracic hypothesis. we questioned how thoracic kyphosis affect disc degeneration. The preoperative thoracic kyphosis was significantly lower in disc degeneration group. Moreover, a higher proportion of preoperative and postoperative thoracic hypokyphosis was significantly observed in disc degeneration group. Longer spinal segments at lower LIV and persistent thoracic hypokyphosis to the post-operative status may increase the predisposition of disc degeneration. Therefore, restoration of normal range of thoracic kyphosis and limiting the fusion length can positively affect the development of disc degeneration. In summary, AI surgery have been developed with new spine instrumentation and correction method. Fusion level selection is the most important single factors. However, no definite guideline for fusion level selection have been established. Therefore, thorough validation study of controversial issues should be needed in the future. Thank you for your attention.
Thank you for the Dong-Gune Chang's talking, and we have a 5 minutes question and answer. And there's any question from the panels? Yes, may I start the question? Dong-Gune.
Yeah.
And as you said, the touched vertebra is idea LIV in the thoracic scoliosis, but in the Lanky type 1 or 2, the lumbar, the modifies B or C is your idea is also suitable for this scenario. I mean the type B and C lumbar modifier.
Yeah, I agree with your opinion because but how we didn't subgroup analysis type each type. So in this study, the conclusion is well, we even if we fuse the longer fusion segments, it causes corona imbalance because long fusion. If we stop the short fusion, it's this adding one. So usually before study, I think only short fusion is problem, but sometimes in thoracic curves we have fusion level, long fusion level also cause the balance problem. Yeah. So yeah, but finally, we do not perform the subgroup analysis. So I don't. But I guess the maybe the same results each type. Yeah. The further study needed.
Thank you very much. Is there any question?
I have
okay.
I have a question. Thank you very much for such a nice lecture. My question is on direct vertebral rotation. In the correction of thoracic scoliosis, in addition to the coronal correction, there's also this sagittal correction. All right, it's a three-dimensional correction, which DVR tends to correct. But there are certain components in these planes. Like for example, in the coronal plane, you need to have lengthening of the concave side and a shortening of the convex side to achieve the coronal correction. On the sagittal plane, you need to have a separation of the screw heads on the concave side to achieve the kyphosis, and in some ways, a reduction in the space between each screw head on the convex side so as to reduce the rib hump So does DVR achieve these passively, or do you at the same time use differential rod contouring and also concave side screw head distraction and convex side screw head compression to achieve these three-dimensional effects? Or is just that DVR is done and all these things will be achieved automatically?
Yeah, I agree with it. It's various reduction maneuver for each institution. In my institution, it's different other institutions, but in our institutions, usually Professor is we only compression, not in corona correction. We usually use the convex compression, not distraction to concave side. So DVR is important for corona correction because if we DVR in distal UIV, LIV, the oppositely main curve, we also achieve the both coronal curve correction and the distal unfused curve, more spontaneous correction. This means but the DVR direction and the rotational force according to the deformity, rotational deformity. So it means, and the sagittal plane, there are several methods to correction of achieve the thoracic hypothesis. For me, I usually achieve the thoracic hypothesis using the rod bendings. So if I check after all achievements, but coronal curve correction is well achieved, but in regular X-ray, not good achieved the thoracic hypothesis. I remove the rod and the more bending. So, and then reinsertion. So it's very important for, I think, because as my final, I introduced my final the study. Thoracic hypokyphosis is affect disc degeneration. So I usually achieve the thoracic hypothesis rod bending. Well, at first time, I rod bending more than 40% of normal hypothesis, but when I inserted the rod and the hypothesis a little caused the hypokyphosis, but I checked it's not at that good condition. I removed the more rod bending. So
Thank you for your answers. And following the speaking of Professor Wong, and I want to ask Professor Wong a question. What's your experience to restore the thoracic kyphosis?
Well,
What's your
I use differential rod contouring, meaning that on the concave side or where the thoracic lordose hypokyphosis, I over contour the rod, and on the underside I under contour the rod. And then it's important to distract between the screw heads, because if you can imagine, you have a curve like this and you want to reach up like this, certainly the screw head distance must increase. Otherwise, if you just lock the screw head and even if you try to do an in situ contouring, it's not going to work because the screw heads need space, to get a kyphosis. So I feel that this appreciation, I mean, I find it very helpful in understanding this. And that's why I'm interested to know from Professor Chang about whether he just used the DVR alone and not use the other methods to get the distances between screw heads. So I use differential rod contouring. I use a concave side distraction to restore the kyphosis. I do a little bit of the convex road side compression, but that does reduce the kyphosis. But sometimes the curve is so stiff, even if I use a strong rod, 6mm cobalt chrome, the rod just bends back. Yeah, this rod just bends back. So we try, but that's not always work. Yeah.
Thank you for your comments. Maybe Kai Cao, we have need to next session.
Yes, I shift the microphone to Dr. Dongku.
Yeah. The second, I introduced the next speakers is a current concept in non-fusing in AIS, Jason Zhang from Hong Kong, please.
I'd like to thank APSS for inviting me to give this talk on current concepts in non-fusion for AIS. No disclosures. So we're speaking about VBT today. It is quite important alternative treatment for AIS population. However, it's not for everyone. We know from the literature that probably best candidates are those who still have growth remaining, COB that are not that severe, and probably still needs to have some inherent flexibility. Nowadays, I think there's an increase in interest in performing this for the lumbar curves because we want to extend indications to prevent fusion in the lumbar spine and protect the mobility for these patients. It relies on this Hütter-Volkmann principle in which you limit the column growth asymmetrically. And this can allow motion to be still be present for our patients and also maintain the normal disc morphology for these young patients. So you have a case like this where you have a curve that's relatively not that severe with inherent flexibility. You can see here on the Falcon bending images, and post-operative, you can see that correction is relatively quite acceptable, maintaining good coronal and sagittal alignment. One of the biggest benefits for VBT is to allow patients to have a quicker return to their usual activities. So for patients, as you report in this study, that most of them can actually return to even contact sports within just 1 to 3 months. And all of them do return to their usual sports. However, for fusion, most of them actually will need to avoid some of their contact sports, even up to 12 months. In the study, they found that the HRQL was quite similar between the two groups, but in general, for VBT group, patients are less likely to give up activities. This other study looked at 3 years down the line, and they showed that actually both types of surgery do provide good outcomes in terms of HRQL, but obviously those who have done VBTs will have higher expectations for return to sports. It is important, however, to understand what we tell our patients. There's a couple of studies that recently published showing that preferences are very important for both the patient and the family. So those who have needs of better trunk appearance and don't have a big concern for spinal motion probably may do better fusion. But however, those who have expectations of maintaining mobility and preserving the normal anatomy will be more inclined to perform a VBT. It's important to note that because of those concerns, there need to have a good rapport with patients and family, and explain to them that this procedure does carries a lot of additional risks of complications that are not present in usual posterior spinal fusion surgeries. So we publish our perioperative complication C is quite high for pulmonary complications, up to 1/3 will do have some sort of respiratory issue to deal with in the perioperative period. Usually, especially with thoracic VBT, you see this happen more prevalent. Two of the more major complications that we do see include tether rupture and overcorrection. So for tether rupture, I think it's quite well established that this is quite common in VBT patients at some point after surgery. Most importantly, of course, is to hope for this to happen later on where growth modulation has already occurred. In general, those who consider a failure and may require revision is those who will have more than 35 degrees after the tether rupture for these patients. The risk, of course, will be much higher in the lumbar curves because of the likelihood of more mobility there. And this one study looked at some risk factors that may contribute to the tether breakage. In general, those who have a higher curve magnitude limited flexibility may have a higher risk of tether rupture. And you do want to have a good correction intraoperatively to avoid too much pressure on the device. So this is one such patient where even if tether rupture happens, it may not actually require revision surgery. So you can see this patient underwent a double tether. And then initially a pretty good correction. Subsequently, at the second year, there was a rupture at the lower segment of the lumbar curve. But it does only rebound to around 20-something degrees, and this was quite stable because at this point, patient, as you can see with the RISR, is quite mature already, and so there was no further progression, and that this was acceptable to the patient. However, that may not always happen. So this is one case who was a bit younger, with curve around 50-something degrees at surgery. And after correction, you can see that it was inadequately corrected, only down to 34 degrees, and that had as reported previously, an increased risk of rupture. You can see here going to 40, back up to nearly 50 degrees, requiring infusion subsequently. Some patients suggest maybe requiring more rigid devices. So these patients with double row TVBTs, and that might actually reduce the risk of the tether breakage. But a lot of times in the Asian population, it's very difficult to fit in 2 rows. So this is one Caucasian patient I operate on, in which I could put in 2 rows, but it's not as technically feasible in most patients. And also, the main point of these surgeries is to allow mobility. And if you put in double rows, there's a risk of you making it more and more stiff and losing that initial need. In general, success VBT probably does rely a lot on growth modulation. So that's why we normally only suggest these for patients who are still growing. And you can see here with growth modulation, in this study, most patients do have a successful result, but those without growth modulation, you can see here at the bottom, a patient who doesn't have the best result because there's no further correction, and it's mainly as an in situ kind of internal split of the curve. Tension effect, it does have a great influence on the outcomes. By tensioning enough, you will have better correction intraoperatively. However, there is some concern with, as reported in this study, where you over-tension patients, you might actually limit the growth. So there is still a need to understand this a bit better with future studies. Overcorrection is the other concern that may happen for VBT patients. So in general, it's quite intuitive. For patients who have a lot of growth remaining will have a higher chance of overcorrection. Those who have less growth probably have less. And so accordingly, you probably need to tension and correct the curve as such. So less correction in the younger patients and more correction in older patients. So you see this one patient, relatively a little younger, and actually immediate post-op, but probably complete correction a little bit too much, and so there was a bit of overcorrection in this case. But it was only 20 degrees, and we accepted it at this stage when she was mature. However, that doesn't always happen in another patient, relatively mature, 51 degrees, and after surgery, you can see there is progressive overcorrection, which we had to go in to remove the implants. Fortunately, that actually rebounded a little bit better, and so it kept in this pretty good state now 6 months post removal. I think in general, it has to be a good understanding of what patients do require VBT, what patients should probably do better fusion. A lot of literature out there would suggest that in general, fusion does result in better outcomes in terms of less revision, overall alignment, and appearance. And in general, these studies show there's no difference in HRQL, but it's important that a lot of patients do request this because of different needs, right? They want to maintain the mobility. All right. In the thoracic curve, I think it's less as apparent in the lumbar curve as compared to lumbar curve because some studies showed here that the kinematics of actual fusion and a VBT might not be actually that much different in the thoracic curve, but definitely this is present in the lumbar curve. And so there's a move towards, really trying to have motion preservation with the lumbar curve rather than for the thoracic curve. And we may even consider doing a hybrid technique such as this. A patient will have a relatively stiffer thoracic curve, lumbar curve is quite significant as well. As you can see here, flexibility, and perform diffusion of thoracic spine and a VPT at the lumbar spine to preserve the mobility. So in general, VBT is a very promising alternative technique for tooth fusion for immature patients with scoliosis, maintains mobility and spinal flexibility, but there's still high risk of tetar rupture, and how to really fine-tune amount of tensioning and correction still needs further understanding. In general, we perform a lot of personalized decision-making for our patients. Thank you.
Thank you, Jason. Do you have any questions? In Korea, we had not accepted in the tethering technique, so I have no experience. But I think the indication is very important. Jason, what's your main indication for non-fusion technique in AIS? How do you select patient appropriately?
Yeah, so I think there's two aspects. One is really indication based on the curve itself, and also the indication based on the family's needs. I think first of all, of course, in the slides you note that the curves are in the general range, not really that severe, right? You're talking about my general range of cob angle that I've done is 40 to 80 degrees, and it's a little bit extended beyond, I think, curve size and what is reported in literature, because I look really a lot at the flexibility. If curves are flexible, I don't think even at 80 degrees is a big issue. The couple of cases I've done that reach that range, if they're corrected quite well, they don't actually have that issue with early tetar rupture and breakage. But also, of course, growth is really important. So looking at patients' bone age is crucial, and I try to get these patients to have the surgery done as soon as possible to try to keep them within that window, right? That there's an opportunity for growth modulation. Doesn't mean that a patient who is pre-menarchal and Rizor zero triradial cartilage is open will have growth modulation, and doesn't mean that someone who is post-menarche and whatnot will have no growth modulation. I think it's still a bit of a mystery to most of us. I think it still needs a little bit more understanding regarding that. The second thing I mentioned was really the family's need, because it's very important to explain to them very carefully what is the current stage of VBTs, because it's very easy to sell this technique to I would say to people, because if they hear all these positive things about this VBT, non-fusion, you preserve mobility, everything, obviously a patient will choose this over fusion, but they need to understand very clearly that there is a huge increase in chance of revision as compared to fusions, because we all know fusions generally do very, very well and we don't need to revise them. But there are a big opportunity for these patients to receive another surgery in the future because of those complications I mentioned. So I always explain them very clearly. So these are the situation. You can choose either one, but it really depends on what they really need.
Thank you, Jason, for excellent talk. Can I ask you a few questions? Leok Lim here. So it's regarding the first question in terms of the hybrid technique, thoracic fusion, lumbar hybrid with the VBT. What are your selection for hybrid technique in the lumbar region?
Yeah, so those cases where it's generally very stiff, right, in the thoracic curve, I think it's and also there's a big deformity, like for example, a huge hump, huge rotation deformity. Sometimes I talk to the patients and say, look, the issue of the correction, right? So you expect a fusion will get a very good correction, while VBT probably is suboptimal as compared to the fusion. So, we look at what they need, right? If they want more cosmesis correction with that, I think the benefit of the thoracic VBT there is much less than a fusion. So that is something we can consider for them. Another consideration is also the size of the lumbar curve is also, if you want to actually do the fusion first and then do the tether, I feel like that actually improves the ability for the lumbar curve to still remain, lumbar tether to remain intact. Breakage is, I of course, this is just anecdotal, right? I need to have longer follow, more cases to understand this. But so far, at least if with the thoracic fusion, lumbar tether rupture rates are quite low. So I think, you probably have done some derotational or, of the lumbar curve due to the correction of thoracic curve, and that actually probably reduces the amount of strain onto those on the lumbar tether. So that potentially is a reason why I see less breakages there.
Thank you, Jason. Because of time limit, we will finish these topics. Thank you for your nice presentations. Okay, the next is Kai Cao. Please introduce. Maybe okay, I introduce the next speakers. The complication after surgical treatment of scoliosis. Shinji Takahashi from Japan, please.
Thank you for introduction. I will share my presentation.
Good afternoon. I'm Shinji Takahashi from Osaka Metropolitan University. Today I will review the complication after surgical treatment of AIS, focusing on intraoperative, early postoperative, and long-term issues. The majority of cases achieved a favorable outcome, but we sometimes encounter the surgical complications. Much of our understanding comes from the SRS M&M database, which includes more than 84,000 cases. Mortality rate is about 0.01%, and the rate of neurological deficit 0.3%. Surgical site infection is reported as 0.5%, and implant complications is 0.2%. However, since it is self-reported by surgeons, record bias likely leads to underestimation, especially of minor complications. In the other reports from Malaysia, neurological deficit is 0.5%, superficial wound infection is about 1%, the total complications about 2%. How to manage the complications? This presentation is to summarize the spectrum of complications encountered after AIS surgery, review their incidence, risk factors, and management strategies, and emphasize the importance of prevention through the surgical planning. Regarding neurological deficit, the main cause include spinal cord ischemia or stretch during collection, direct trauma from instrumentation, and systemic factors such as hypertension. Nerve root injury may also occur during screw placement or corrective maneuvers. To prevent these injuries, intraoperative neural monitoring is essential. SSEP are sensitive but slower to respond, while motor-evoked potentials detect motor tract compromise more quickly. Free-run and triggered EMG are variable for verifying pedicle screw placement. Multimodal monitoring combining SSAP, MAP, and EMG is now standard. According to an SRS survey, most surgeons prefer a multimodal approach, particularly SSAP combined with MAP, as this provides higher sensitivity and faster response to cord compromise. When a new monitoring alert occurs, possible causes include anemia, low mean arterial pressure, screw irritation, overcorrection, or direct compression by pedicle or ligamental flabum. Management focusing on correcting these reversible causes. And next, the pedicle screw complications include malposition and cortical perforation. Large multi-center series report critical pedicle perforation rates of about 1.5% and anterior perforation rates of 0.7%. Symptomatic radiculopathy is fortunately very rare, around 0.1%. Thoracic scoliotic pedicles show variability. Most are cancerous channels, but some are narrow cortical or slit type. The trajectory of pedicle screw depending on the shape of vertebral body, and the perforation of anterior vertebral cortex is a known complication. The incidence is about 3%. And the perforation of the anterior vertebral cortex is a recognized complication. Structure at risk in the upper thoracic spine include the trachea, esophagus, and bronchi. And we have to pay attention to the location of the aorta. At T12, the aorta is in front of the left pedicle and moves to the right side at the lumbar level. During the follow-up, we also encounter the Dong-Gune phenomenon. The complication following surgical treatment of ARS in a 10-year prospective follow-up shows the Dong-Gune incidence rate is about 2.5%. And also in 10 years, 7.7% of patients underwent the operation in this series. With the goal of saving more mobile lumbar vertebral segment, selective fusion of the main thoracic curve is an effective surgical treatment of Lanka type 1 and 2. However, this procedure is associated with several problems, including a distal Dong-Gune phenomenon. Usually, Dong-Gune is defined as the more than 5 degrees increase in the curve angle or the new distal disc angulation more than 5 degrees below the LIV. The incidence rate is about 10 to 20% in the Lanka 1 or 2 curves. Several risk factors for Dong-Gune are reported. Skeletal immaturity includes open triradiate cartilage and RESA 0 to 2 grades. Selection of an inappropriate LIV, such as particularly stopping short of the last touch vertebra, and deviation of LIV plasma more than 10 mm from the midline, and the overcorrection of main curve. To prevent distal Dong-Gune in thoracic curve, the preoperative last touching vertebra was identified on standing full-length radiographs. Last touch vertebra was the most caudal vertebra of the main thoracic curve that was touched by the CSVL. Last substantially touched vertebra, which was defined as the most proximal lumbar vertebra where the CSBL either intersected the pedicle outline or was medial to the pedicle outline. Selective substantially touched vertebra as LRV could yield a promising outcome for Lanka 1A scoliosis patients undergoing selective posterior fusion. For skeletal immature patients, surgical treatment may achieve greater correction. However, in some cases, it may cause biomechanical changes leading to a secondary progression of distal adding on. An extra distal level may be considered to reduce the risk of progression adding on. The flexibility is important in terms of shoulder balance. Shoulder imbalance may lead to the risk of adding on. Shoulder imbalance is measured using radiographic shoulder height, clavicle angle, or T1 tilt. It results from inadequate correction of the proximal thoracic curve or disproportionate correction of the main thoracic curve. So, however, over time, patients often adapt. The shoulder balance can improve as they adjust posture, and minor imbalance may resolve spontaneously within 1 to 2 years post-operation. Preoperative high shoulder stiffness of the proximal thoracic curve and overcorrection of the main curve are key risk factors. In Lanka type 1 and 2 curves, correcting the main curve by more than 54% with undercorrection of the proximal thoracic curve resulted in imbalance in nearly 60% of patients. So, to prevent shoulder imbalance, follow fusion level guideline for proximal curve. If the patient meets criteria of the thoracic curve, and for instance, fuse to T2 if the proximal thoracic curve more than 30 degrees, the proximal apex rotation grade 1, proximal thoracic curve doesn't bend less than 20 degrees or at least significant pre-op shoulder elevation. And in terms of long-term outcomes and management, I want to introduce 3 papers. So first one is 30 years after surgery, ARS patients have more pain and worse physical function than their peers. However, the differences are not clinically relevant except for pain and physical activity. But at the mean 41-year follow-up period, maintaining the LIV at L3 or higher, achieving good sagittal alignment, and maintaining lumbar lordosis may help prevent long-term disc degeneration in ARS patients. And in the study, the mean follow-up 45 years by Harrington instrumentation, LIV L4 or distal had a higher rate of undergoing an additional surgical procedure than those with LIV L3 or proximal. Take-home message: neurological deficit is rare but devastating. Neuromonitoring is indispensable for safety. Implant-related issue: understand ARS pedicle anatomy is very important to minimize risk factor with navigation. Adding on and shoulder imbalance, the stress critical role of selecting proper fusion levels. And surgical planning, dynamic radiographs are essential for preventing complications. and the revision and long-term outcomes, balance correction with motion prevention, and also for LIB, L3 or proximal is preferred. Thank you for your attention.
Thank you.
Thank you very much, Shinji. And is there any questions from panel? Speaking of the complications of the surgery, what is your routine measurements you will take if when you are facing you lost the signal during the surgery?
Yeah, thank you for the question. So, as I mentioned, I will check the patient's the bleeding and the blood pressure, and if the blood pressure is too low, sometimes I will ask the anesthesiologist to increase the blood pressure, and sometimes I think also check the body temperature of the patient, and if there is no improvement of the signal after the routine checking, I will I will do wake up test, but it's very rare. So if I have no other critical reasons, I think I will check the patient's motor condition after the surgery.
So do you release the implants? Do you release the implants to observe
yeah. So after the correction, if the especially in the patients with the severe scoliosis cases, so I will reduce and release the implantation.
I can ask a question. Shinji, thanks very much for a nice talk, very comprehensive. If you are faced with a patient with coronal imbalance, for example, after your surgery, like that case that you showed with overcorrection of the main thoracic and then the body is shifted over, or sometimes when you feel to very low down, right, L4, L5, and the trunk is shifted to one side, what would you do? I mean, would there be a situation where you would tell the patient, say, okay, we need to go back and correct this, by reducing the correction or by doing something? Do you have to do that?
Yeah. So I sometimes, but I usually will reduce the correction, I think.
You will go in a second time to reduce the correction.
Yes.
Kai, it's time to finish.
Thank you.
Thank you, Shinji. Because time limit, we move to the next topics. The next topic is case presentation. So the topic is Lanka type 1 AIS fusion case by Chris Chan from Malaysia. Please.
Thank you very much for this introduction. I'm Chris from Malaysia. I have no disclosures which is related to this presentation. So this is a 15-year-old girl. She's 3 years post-menarche with a chief complaint of rib hump and waist asymmetry. Otherwise, she's healthy with normal neurology. There's no neurocutaneous stigmata and there's no hyperlaxity. On assessment, the scolometer on the thoracic curve measures 30 degrees, whereas for the lumbar curve is 0 degrees. Plumb line is plus 20 millimeters, and as you can see, she has a very prominent rib hump as well as a lumbar crease. There is no neurocutaneous stigmata, there is no hyperlaxity. So if you look at the patient from the front, we can observe that the right shoulder is higher by about 10 millimeters, and there's a neck tilt of grade 1, and the neck is tilted to the right side. On radiological assessment, the main thoracic cup angle measures 83 degrees, the proximal thoracic cup angle is 36 degrees, lumbar cup angle is 43 degrees, patient has a coronal imbalance of plus 20 millimeters. The radiological medial shoulder parameter shows that the T1 tilt is minus 3 degrees. The C1 CSVL, which reflects the neck tilting, is plus 6 degrees. And the lateral shoulder radiological parameters, clavicle angle measures minus 2 degrees. From the side, we can observe that the T5 T12 kyphosis was 13 degrees, T10 L2 kyphosis of 8 degrees, L1 S1 lordosis of 48 degrees, and patient has a PI of 38 degrees. In our center, we perform supervised side bending. So on the left side supervised bending, the proximal thoracic curve corrects to 20 degrees, and the lumbar curve corrects to minus 3 degrees, whereas on the right side supervised bending, the main thoracic side bending corrects to 34 degrees. So the diagnosis is adolescent idiopathic scoliosis, lanky 1AN, type AR curve. So I'll stop here to get the input from the experts.
Thank you for your presentation. Do you have any questions?
So the following is let panel to choose the UIV or LIV, and is that right?
Chris, can you show us the standing X-ray?
May I suggest the moderators just call out the experts to discuss, except for me.
Can we see the
Okay, so this is a standing radiograph. Yeah. So additionally, the neutral vertebra is L4, the substantial touch vertebra is L3, and the stable vertebra is L4. Yeah.
In my opinion, usually I select a single thoracic like this, and it's usually UIV is I go to the neutral vertebra L4, and because single thoracic curve. So and the distal is usually neutral vertebra or touch vertebra. Which is the neutral vertebra?
The neutral vertebra is L4.
L4.
Yes.
Yes. Its end vertebra is?
End vertebra is L1.
Yeah. In subclassification, the gap difference end vertebra and the neutral vertebra more than two vertebra usually stop the neutral vertebra -1. So L2 is L2 or L3 is okay. This stuff, I think.
For me, of course, we like to look at the real flexibility by the fulcrum, but I think the side bending already shows that it's actually not really that stiff. For me, I would try to stop a little bit shorter to the L2, just like Dong-Gune, but my concept is really just at the using the touch vertebra concept, but I think with a bit more releases and multiple screws, I think it can get her quite balanced, and try not to go L3 if possible. But what I also like to look at is the flexibility of the L2-3 disc on its two bending. If the bending shows that the disc is still quite mobile, I think it's still a good option to stop at L2 versus the L3. So here you can see at least it opens up quite well. The upper instrumented vertebra, I think I would stop at T4. The right shoulder is higher. There's no significant scapular hump clinically. I think we don't necessarily have to go so high. So I would choose for T4 to L2. This patient also sagittally looks hypokyphotic or even lordotic. I'm not sure. In the thoracic spine. So this patient will probably try to regain a little more kyphosis. And what I commonly do in these couple of years is really be more aggressive with more Ponti releases, and that may try to actually improve the sagittal alignment as well.
Chris, do you usually perform the thoracoplasty?
No, in our center, we do not perform thoracolplasty. So Dr. Chang, what is the upper instrumented vertebra which you would choose for this case?
Upper instrument is usually, this case is a single thoracic, not double thoracic, so I usually neutral vertebra, T4.
Neutral would be T5?
Yeah, maybe neutral vertebra.
Okay.
Yeah.
Shinji, what about your center strategy for this case?
Or I think depending on the proximal thoracic flexibility, I think the left side bending the proximal thoracic scoliosis is reduced to less than 20.
No, it's a 25 on side bending. Yeah.
20. Okay, so
20 for side bending.
Okay, so I want to choose the UIV at the T4 and the LIV is the L3. So usually we choose the LIV at the significant last touch vertebra.
Prof. Wong, any pearls from your side on this type of case? What is your surgical strategy?
No, I would treat it. I think that this is a fairly flexible curve, and in the long past, actually, I did anterior for these as long as the side bending is less than 40 degrees. It's just that there's a lot of work anteriorly, too many discs. So I usually nowadays just do posterior for this. Probably T3 or T4 on the upper end because the thoracic looked very flexible. And then I would choose L3 lower down. And I would agree with Jason that Ponti osteotomies are very useful in getting the correction of the kyphosis because I've said just now earlier that you need lengthening of that column in the sagittal plane as well. And the Ponti releases allow the spine the posterior thoracic elements to separate to achieve that kyphosis.
Can I ask a question to both Prof. Wong and to Jason? When you perform a Ponti osteotomy and when you perform a distraction maneuver over the posterior aspect of the spine, would it open up a gap on the bony surfaces? And in that case, then where would you place the bone graft?
I don't care much about that because posteriorly I still have lamina there, and I haven't had a case of non-union. I think I like to always quote Prof. Look's very funny comments in the past, right? You can spit on AIS and they'll fuse, right? AIS always fuse, so I don't think there's an issue there. You still have bony contact on posterior surface. The convexity is compressed down. You have a lot of bony contact. I don't think there's an issue by opening up the concavity.
I have exactly the same opinion. I have never grafted over that area, and after so many decades, has been okay. Touch wood.
Okay,
Maybe
that means you don't place bone graft at the levels you perform the Ponti osteotomy?
No, I don't.
Okay, all right.
maybe Dr. Sakai is have a question. Yeah.
Yeah, I recently, well, for a couple of years, I've been using the traction intraoperatively, and looking at the shoulder balance, I tried to look at the estimation of how much T1 tilt reduces when we do intraoperative traction just before the surgery on the table, and measure the T1 tilt. If it reduces, or if the left side goes prominently up, then I would raise a few levels for the fusion levels to control that, to press it down. If not, I would stop at T4 as mentioned, and maybe stop for the UIV as well to traction. If there is great reduction of the 2-3 disc, I'll go to L2, and maybe not, then I'll go down to L3. So anybody uses traction for doing assessing the shoulder balance beforehand for the fusion levels?
I don't think traction.
We don't, yeah.
It's
I don't-
actually quite working. So yeah, we're looking into that. Just a comment.
I find that if I have some sort of indecision as to whether it should be the more cephalad or more caudal level, I usually choose the more cephalad level, because I think that sometimes the rigidity or the flexibility is not always well shown. So I think that if you have any doubt, I would always end up more cephalad. Yeah, because I think there's not a lot to be lost to go up further, because that area is rigid, the ribs are short, and for that same reason, because the ribs are short, the correction to get back the balance, it's harder to achieve if you don't have enough segments.
Dr. Kai Cao and Dr. Chang, should I proceed to what was done?
Yeah, please proceed.
Okay, so the next section is just to share what we did in our center. So from the left and right supervised side bending, we normally will calculate the side bending angle to the left and right. We used our center's formula to decide the UIV tilt angle. In this case, we selected T2. So the average of the right and side bending was 7.5. So the targeted UIV tilt angle was minus 7.5. We used the left side bending to determine the LIV tilt angle. And in this case, we chose L3 as LIV. So the targeted LIV tilt angle at L3 was 0 to 5 degrees. So intraoperatively, we used an intraoperative crossbar to confirm whether our target was achieved. So as you can see on the left, the intraoperative UIV tilt angle was -3, intraoperative LIV tilt angle was +3. And this is the 2 months post-op radiograph fusion from T2 to L3, which shows the correction of the proximal thoracic curve from 36 to 21 degrees, main thoracic curve from 83 to 28 degrees, lumbar curve from 43 to 10 degrees, and the T1 tilt angle at 2 months was +1, clavicle angle was -1, but there's still a significant residual neck tilt of 7 degrees. At 2 months, patients still had coronal imbalance of -19 millimeters. At 1 year follow-up, when the patient was more balanced, these are the radiological parameters. The medial shoulder and lateral shoulder parameters were balanced, but patients still had some residual neck tilt of 8 degrees. The UIV tilt angle at final follow-up was -6 degrees, and the LIV tilt angle was +2 degrees. So this is the lateral profile. The T2, T5 angle was 16 degrees, T5, T12 was 10 degrees, L1, S1 was 43 degrees at 1 year follow-up, and T2, T12 angle was 26 degrees. So this case illustrates a lanky 1 AR curve, and there are many papers which reported higher incidence of adding on phenomenon in this variant of lanky 1A curves. However, it is not that well documented, the risk of medial shoulder imbalance in lanky 1 and 2 AR curves. So the reason for this is basically we are trying to compare a proximal thoracic curve and a main thoracic curve in such cases whereby it is known that for the AR curve particularly, the main thoracic curve is less stiff. Secondly, if we look at the number of vertebrae which are available for anchor, like in this case for proximal thoracic curve, we have only T1 to T5, which gives a maximum of 10 anchors. Compared to T6 to L3, you can have a maximum of 20 anchors. Furthermore, we know the concave aspect of the proximal thoracic curve. Normally, we require extra pedicular screws, which are inherently weaker. And of course, so the race between correction of the proximal thoracic curve and the main thoracic curve is generally not a very fair race. And therefore, this predisposes the patient to over-correction of the main thoracic curve, leading to higher risk of medial shoulder imbalance. So the key points to prevent medial shoulder imbalance, number one, is to increase the proximal thoracic screw density. Secondly, normally we would choose a higher UIV at T2 and even sometimes at T1. Third is to let go of the main thoracic curve correction. Sometimes we reduce the screw density, we bend the rod. And fourth is to prioritize proximal thoracic correction first before main thoracic correction. Thank you very much.
Thank you. Your nice presentation. But I'm okay. Dr. Sakai have question. Yeah.
Thank you, Chris. Thank you for that. So you mentioned reducing the main thoracic curve, letting it go. If it so how do you balance between the thoracic kyphosis versus medial neck tilt? You know, you're taking which is for all the patients, right? You balance.
So in our center, so every center have their own priority in terms of the aims of correction. So in our center, the priority is to get a good middle shoulder balance. So firstly, we would prioritize the proximal thoracic correction, but to incorporate that to obtain a satisfactory sagittal balance, we would increase the kyphosis over the proximal thoracic segment as well. Because in our center, we would perform a distraction over the T2 to T5 region, as well as to create a proximal hyperkyphotic rod so that the kyphosis is placed mainly over the proximal thoracic curve. If we increase the kyphosis over the T5 to T12 segment, what we notice is sometimes this would result in unsatisfactory cosmetic appearance of the rib hump. So for T5, T12, generally we try to intentionally perform a hypokyphosis so that the rib hump appearance is preserved. But the main aim for us is to actually maintain or improve the global kyphosis over the T2 to T12.
Okay, thank you.
It's very interesting. Your group is very specialist for shoulder balance, but I wonder in single thoracic curve, we are more proximal fusion level more than up to T1 to 3 is for me it's very interesting. Yeah, so
yes.
yeah.
I think that if you ask whether you can stop at T4, T3, yes, I believe you can stop at T4 or T3 as well. Just that probably we will need to understand how the proximal thoracic curve compensates for the correction over the main thoracic curve. Because if you stop at T4, the correction is mainly performed over the main thoracic curve. So we need to understand the behavior of how the proximal thoracic curve compensates for whatever correction we perform over the main thoracic curve. So in short, yes, you can stop at T3, T4, but it's less, I would say it is less easy to predict what will happen after the operation and whether you can gain control of the middle shoulder balance after the surgery.
Thank you for your nice presentation. Because of time limit, we will move the next speakers. Kai Cao, please.
Thank you very much.
The next speaker is Lau from Singapore. He give us a case presentation, Lanky Type 1 AIS VBT case. Please welcome.
Leok Lim, you're muted. We can't hear you.
Good afternoon. Thank you, APS, for the invitation to invite me to this platform. I've been given the task of a case presentation 2, Lanky 1, VBT.
Dr. Lim, please, your monitor is full screen, PPT.
It is full screen now.
Yeah.
Right, so
Leok Lim is still appears as split screen to us.
You can go to slideshow, Leok Lim. Yeah, just press on slideshow.
I'm doing that exactly. Is it full screen?
I think you
No.
have to share the other.
Right, okay. Is it full screen now?
Do you have double monitor?
So kindly unshare and reshare again.
So you have to share the full screen slide. So
Sound is perfect.
All right, okay. So good afternoon. Thank you, APS, for the invitation to this meeting. Here are my disclosures. The case I'm going to present on is a 15-year-old female who present to us with scoliosis. It was picked up during scoliosis screening program at school. She is active at environmental club. Her menarche was a month earlier. On examination, you could see that her height was 149 cm. Her sitting height was 175 cm. She's shorter than her mother.
Dr. Lim, sorry, we cannot see your PPT.
Yeah. We cannot see your PowerPoint.
Can you see now?
No, still not.
No, cannot see.
Share your slides. Yeah.
Can you see now?
Yeah.
Yeah, we can see
But
that,
not
but
full
not.
screen.
Are you using a presenter view?
I would switch to here.
Yeah, I think it doesn't work.
Can you see now?
No, I think it doesn't work.
Okay.
So let's go on. That doesn't matter. Okay, let's go.
All right, okay. Can you see now?
Yes.
Yeah, we can see, but not the full screen. But I think it doesn't matter. Please go ahead.
Yeah, so this is her curvature. She is 23 degrees in the mean thoracic, and her lumbar curve was around 11 degrees. She's Risa 0, Sanders was 3, and she was prescribed a brace. And it was during COVID time at the period, so she returned with a brace 5 months later, and you can see that in brace X-ray, her mean thoracic curve has progressed to 28 degrees. Her lumbar curve was 21 degrees. Sanders was Sander 3 at the stage with Risa 0. Now, 6 months later, she presented to us for review. You could see that her curve has progressed from 28 to 40 degrees in the mean thoracic curve. Lumbar curve was 30 degrees. Her right shoulder was high, and her mean thoracic curve on ATR was 13 degrees. Lumbar curve was 10 degrees on ATR. Her Risa was at stage 1 and Sanders was stage 4. Now, what would you do at this stage? Now, may I just have a poll of who is doing a VBT among the experts in this panel?
I think Professor Wong do VBT and Jason do VBT, and I'm not sure other panels who is doing VBT.
Yeah, it's not available in Japan as well.
In Korea, no VBT.
We have no VBT products in China also.
So Singapore, Hong Kong, how about Malaysia?
We don't do VBT in our center yet,
Right.
but it is available in Malaysia.
Right. So I think Prof. Wong raised the hand. Prof. Wong, do you have any comment?
No, I raised the hand because you asked who are doing, so I raised my hand.
Right. Okay. So in this, despite the 15 years old, this girl is relatively immature. Medical was just a month earlier prior to presentation, and on follow-up for almost a year. Sanders is 3 to 4. At this stage, may I ask what would be the options for the centers that don't do VBT? Maybe we start from Dr. Sakai.
Sorry, can you repeat that?
What would you do at this stage for this patient?
Won't go in operation yet. How old is she? 14, right?
She's 13 years old.
13.
She's 16 years old at this stage.
Oh, okay. So it depends on if the patient will choose surgery or not, and if they do, we'll do a thoracic segmented fusion, thoracic fusion, selective thoracic fusion.
Right. How about at the center that does VBT? Is it the right time to offer the patient VBT? Jason?
Well, going back, I think, well, first of all, I wouldn't even care about a chronological age. To me, that is complete nonsense because bone age is the key thing. So I don't really care if she's 15, 16, or 17. If her hand X-ray looks like that of a Sanders 4, she has growth remaining. So to me, I don't really care about the chronological age. I think it's important to understand what the patient's expectations are, right? Because you've started her just recently on brace and she has progressed in the brace. Because I'm a really big proponent of bracing, or even called personalized bracing. So I like to look a lot more in detail regarding the indication to begin with, and also the flexibility and how she was wearing those 6 months. It's although a little bit of it's strange that it's progressed so significantly from low 20s to 40 degrees in 6 months. It looks like a pretty sinister curve, but understanding a little bit more about the flexibility in brace correction would give some sort of understanding whether this patient has a potential for that curve to improve the curve or not. If she's been wearing very well and it's still progressed, okay, then it is quite a sinister curve. Then I would already start the discussions for VBT. But it was because she had some problem with the brace previously, which wasn't wearing well. You still have that option to mold it better, and because 40 degrees is kind of like that like a controversial area, right? So you can still potentially have some improvement if she had an issue due to brace. But if it's a compliance issue to begin with, and also the curve has been progressing significantly, I think it's probably a good opportunity to think about that.
Right. Okay. Now, Prof. Wong, you also do VBT. What's your opinion in these situations? Professor Wong?
Yeah. I think that I would counsel the patient, speak to the patient about VBT. Yes.
Right. Okay. So I mean, would
I think for
anyone
those
do
of
a
you- Can I
would
ask?
anyone do an MRI scan at this stage? Because Jason raised the fact that this is potentially a sinister curve, 6 months progression over approximately about 10 degrees. Would this constitute a very aggressive curve that one would consider to do an MRI scan?
I don't normally do it if I've done the due diligence, right? If the clinical history appears quite okay. She's just growing significantly at peak height velocity. There's no clinical signs of any concerns, the usual things we look at, when we do our examinations, asymmetry, etc. I wouldn't get an MRI.
I would like to ask those who was it who said fusion? Was it Daisuke? Would you want to do it now or wait until later? And if you would do it now, would you consider anterior fusion instead of posterior because of the risk of crankshafting?
So I would, I would ask for patients' real, records, and also of course, the acquaintance, social activity, many sort of things. I would not do a fusion at this stage medically if there are any indications of needing a fusion right now. And as mentioned, somebody mentioned about having failure of the cast bracing, and so I would check until she is fully mature and offer that. And maybe if she doesn't choose to fuse, no. But if you're right, if I would have to choose to fuse now, doing an anterior surgery is one option to prevent the growth after the fusion.
I mean, in times when we didn't have VBT, I would probably have just continued bracing for whatever it is worth. And I think fusing this patient at 50, 60 degrees is not an issue technically for many of us. So I think at least the spine has growth in length and things like that. I probably wouldn't want to fuse her at 40 degrees now. Yeah.
Well, Profile, I think we had a discussion quite a few years ago when I presented a paper on curve regression. I think that's why I was talking all that stuff about the bracing, because understanding why there was brace failure is really crucial. If it was like compliance, etc., then and not related to brace, then maybe with correcting the brace further, it's potential for the 40-degree curve to improve. And I have a whole case series of these where you reach 40 plus degrees and they actually regress. So I wouldn't say that bracing is useless. I still think there's definitely a role at this stage, but understanding a bit more, I think is important.
Yeah, so to further to your point, Jason, that this patient actually wore the brace, and we use the iButton to monitor the brace time. For this particular patient, it was around 10 hours or so, and she wasn't considered brace compliance in that regards. And secondly, in patient in a peak height velocity, up to 3 degrees progression per month can be expected in certain cases. So factor that in 18 degrees, even up to 18 degrees changes over the course of 6 months will not consider a sinister curve in general, unless progression is much faster than that. Yeah,
well,
so
sorry, maybe sinister is not the correct word. What I mean is like a pretty poor prognostic, really, really rapid. And as I mentioned, I still wouldn't get an MRI for this patient because I think in peak height velocity it's possible to progress that much. But I'm just saying that it's one of those more sinister ones where it progresses fast.
right. And anyone has any other points to put forward?
And I agree with Jason. It's in the controversial region of this stage. Could firstly, I want to find what's the reason of a failing of the brace, and I will take a adjust the range to let the patient in the brace of further for a few times to observe further, and then I make a decision.
Right. Can I present my findings to the moderator?
Sure. Please.
Yeah. So in this case, in view that the patient's wear time of the brace is quite limited, therefore we suggested to the patient for the considerations of the brace for the VBT. So before the VPT procedure, we did a bending X-ray for the patient. You can see that the curve itself is actually quite flexible. The mean thoracic curve from 42 degrees bent down to 20 degrees, and for the lumbar curves, it bent down completely to 0. And so what we did during the surgery is what we would have done for any fusion surgery. We did it from the front in this situation. In order to do the VBT, we need to achieve a single lung ventilation. So some centers do open surgery, but we did endoscopic vertebral body tethering. So patient is placed on the left lateral position with the right side up, positioning as what you can see in here. 4 ports are then inserted at the third, fifth, seventh, and ninth rib spaces, and then we insert a small little port as a diaphragm retractor, as what you can see on this picture. So VPT in this case was performed from end vertebra to end vertebra, which is a T5 to T12. The screws and the staples were inserted sequentially, guided by the X-rays during the insertions. You can see this is at the end of the insertions, and we subsequently put a tether across from the top and sequentially achieving tensioning from the proximal to distal. Most tensioning should happen at the apical zone of the curve, leaving a bit of a lax tension at the end of the last screw. This is how patient look like after the surgery. We typically will do an X-ray at the end of the surgery to ensure that the lung that has been collapsed is reinflated back. Chest tube was inserted during the surgery, and this chest tube is removed on the post-op day 3. And prior to removal, again we do an X-ray to check to ensure that the chest tube is functioning well with reduction of the surgical pneumothorax. In this situation, you can see there's no pneumothorax in here prior to removal of the chest tube. This is a follow-up at one month post-op. So you can see that the up to about 50% reduction of the curve is expected. We got around 23 degrees for this patient. Interesting enough is that the lumbar curve has some auto reduction, which suggested that some of the lumbar curves may improve once you do a main curve itself. At 3 months, again,
The recording has stopped.
you can see that the post-op 3 months, the main thoracic curve maintained at around 23 degrees. At 1 year, the curves at the main thoracic was at 20 degrees, and the lumbar was at 15 degrees. So at 2 years, this is a 2 years x-rays. The curvature was at 20 degrees in the main thoracic, and at the lumbar is at 12 degrees. So in summary, patient selection is a key to achieve a good outcome. BPT have achieved its aim in this situation in medium term. Instrumented thoracic curve correction is durable up to 2 years period with no evidence of any theta breakage. Lumbar spine autocorrection in the non-operated part can be seen continuously over a 2 years period. The ATR correction is possible in flexible curves such as this. Thank you.
Thank you very
Oh,
much.
Tim, can I ask, how did you tension this case? How do you recall at least how much tension you put in for the segments?
Well, this is a Sanders 4 when we went in. So in the main thoracic, we actually go maximally as much as we can. In the lumbar region, in the more caudal region, and we tend to leave a little bit of less tensioning.
How maximal did you go? I saw you used a system where you can use up to 700 newtons.
Maximum we can, we want to see, especially in the apical zone, we go maximum.
Wow. Okay. All right. So yeah, this is the issue, right? You go maximum, you don't see growth modulation happen with time, unfortunately. So I mean, it's still a mystery, I think, to understand this. Okay, cool.
Well, I think up to a medium term, you still can maintain the correction. So of course, theta breakage can happen up to 5 years. I've been reported up to 5 years. I think a long-term follow-up is important. I think the case selection is very important as well.
Yeah, yes, and follow the speaking that do you worry about the overcorrection along with the patient growth if you perform the maximum stress during surgery?
Yeah, I think the reason that we can go maximum is because the patients at the time of surgery is probably Sanders 4, maybe even 5. Right, so if you are Sanders 2 or you triradiate is not close yet, I think the overcorrection can be quite common to the extent that in some of the case series, majority of reoperation is because of overcorrection. So I think in those series, then I think you shouldn't be over-tensioning. In Sanders 3 or 2, or even in cases that you suspect the patient have significant growth remaining. So in this particular case, the patient grew about 4 cm after the surgery, which is not a lot, and hence we're able to do maximum correction without causing much issues. Yeah.
Yeah, I think that this patient is probably fairly advanced in her skeletal maturity, and it shows some of the deficiencies we have in assessing, like the lecture, what Jason said in his lecture. I think that, RESO 1 may not be RESO 1. Sanders 4 could be a 5, right? And at her age, although normally we don't look at the age very much, but I think that if the patient is fairly advanced in age, I think there is also something that a a point that we need to look at. That their spine is probably not as flexible, and they probably won't have as much growth as we think that they have. Yeah.
Actually, the flexibility thing, I think, is a key issue, which, in the past, like, I guess 1 or 2 years, I've been noticing that those curves, this one is quite flexible, but there are some curves that I have that don't go fully straight on my fulcrum bending. And even if I go fully maximum, even at a Sanders 2, I do not see overcorrection. It's really strange, but those who are really, really flexible, I sometimes even just place the cord down and try not to do any tensioning, because those really overcorrect quite significantly. I think flexibility is the third dimension that we need to look at as well.
I think that some of you may not be aware, we actually presented this, we haven't published this, even in anterior spinal fusion with a single rod. In relatively immature patients, we actually see curve correction over time. And not only that, in some of those patients, we had overcorrection. The rod actually bent the other way. We're going to show more of this in time. Yeah. So growth is a phenomenon that we need to learn more about. I think there's still a lot to learn regarding who are the patients who, and there are some patients who are Sanders 4 in this fusion group who actually also bent. Yeah, so it's just we are in need of good parameters.
Hi.
Thank you very much. And I think it's time to shift the microphone to Dong-Gune Chang.
Yeah. This topic is the last session, surgical video presentation, anterior reduction of high-grade spondylolisthesis, presented by Dr. Sakai from Japan. Please.
I think my topic was AS corrective maneuvers.
Sorry.
So, sorry. So, can you see my screen?
Sorry.
Yeah, I can see.
Yeah. Your topic is AS corrective maneuvers.
Yeah. Okay. So we were talking about all these corrections and growth and things like that, and I'd like to just to go overview of the techniques that are been presented today and its merits and demerits and how to choose which to choose. So we are facing the challenges to 3D correction especially in the hypokyphotic AAS cases. So the things that we can consider for making a better kyphosis is to do an anterior shortening and maybe a posterior extension by osteotomy, 360 degrees facetectomy, pontiostenotomies, and consideration of more rigid implants and maybe differential rod contouring techniques. And plus, we have been presented with the shoulder imbalance in terms of selecting the UIV levels and both the LIV levels. So conventionally, we've been using the conventional rod rotation maneuver. It has some limitations, which shows that the large force which is applied on concavity and the rods and screws, which may have some pullouts and worsening of the contoured rod. The extension force applied on the rod reduces the kyphosis, and rotational force that is applied to the rod rotation can actually increase the rib hump. So the Hokkaido group has adopted the dual rod rotation maneuvers with polyaxial anchors, and actually no actual change on the force applied was measured by mechanically on the concavity rod, and it still increases the hump. And the apex of the thoracic kyphosis, which is usually around the main curve apex, if the apex is at T8, T9, that can affect the thoracic kyphosis, which should be more upper in the T4, 5, 6 area. So the movement of this apical vertebra, it moves towards the posteriorly in the this red arrow surface direction, and then which can lead to rod rotation increases with the increase in the rib hump itself. So many of other historical research has done looking into doing more of a translation. It also decreases the rod itself by pull out of the screws or even the loss of rod contour. We've heard about vertebral rotation, which was a significant technique from Korea. It should be done originally on a single rod, but as Dr. Wong has mentioned, in my experience, it cannot really do everything with the rotational maneuvers. You would have to use reducers and also compression and destruction forces while doing this rotational techniques. We now have monoaxial screws and uniaxial screws, which can directly produce the force of the translation or the rotation in 3-dimensional. Since when we only had monoaxial screws, we bended the force was directly bending the rod itself. If you force to place down this screw, if there is a maximal stress would be on the screws or on the rods. Now we do have uniaxial rods, screws, uni screws, which shows a better adaptation of the rod and the screw itself, while a small loss of that corrective force can be applied in that return. Uniaxial and polyaxial screw can also make an impact on the vertebral rotation. You can see that by using the uniaxial screws, you get better axial rotation. So pedicle screw insertion has evolved itself by using robotics and navigation, and also by using the ball tip techniques and things like that. We are more efficiently placing the screws safely into the small pedicles of the children's bones. And the release that we are doing, so facetectomy first, I tend to like to do staged osteotomy by trying to stage the osteotomy by pressuring down on the flexibility of the patient and leveling up. First do a superior facet joint and then posterior facet joint, then to superior, and then a Ponty-like osteotomy on the lamina and the both the outside of the facets, and trying to assess the flexibility that I'm getting while doing the surgery itself. So I don't take out the whole lamina in order to place, have some room for the bone to fuse. Another consideration is the rod rigidity. In the Asian market, we do have cobalt-chrome 6.0 as the maximal stress, but in the North Americans, they still sometimes use the super stainless steel. So we asked ourselves in the Japanese community where if the stiffer rods provides better outcomes as a randomized clinical trial. And the results showed that there was no significant difference between the titanium alloy versus the cobalt chrome in this RCT, mainly because we do have other multiple factors that affects the like the osteotomy numbers and the cases and things like that. So I do prefer a stiffer rod myself, but theoretically, maybe there is not a big difference in terms of correction. Then does more rod during correction provide better outcome was the next thing that I assessed myself. So we used simultaneously 2 rods during the correction maneuvers. We firstly placed the screws. All the screws are augmented with the reducers. The reducers have a long slots that can insert 2 rods at the same time and then tie down the rods end to end where it's close and easier, and then translate the vertebral body simultaneously with 2 rods, and then do the rotational maneuvers, which shows a better thoracic kyphosis outcome. And a little bit, the clinical outcome was not significantly different, but we get a better radiographic sagittal alignment, as you can see here. So we were also wondering about the rod deformation after the rod insertion, which accounts for loss of correction. So we looked into concavity and convexity on the rod, which was placed beforehand. We measured the kyphosis of the rod, and then we measured the kyphosis after the rod was inserted. And we see that there is a significant loss of deformation in the concavity more than in the convexity, which is reasonable. And if the curve gets larger and larger, this force gets better and bigger. So it's mandatory that we understand that there is a more stress on the concave rod. So the differential rod contouring may also account for this issue as well. So there is several biomechanical analysis on this differential rod contouring, and Hokkaido group also looked into biomechanical stress analysis and showed that in order to get a better loss of rod deformity, we would have to place more releases or more implant density, which can reduce the stress on the rods. So these are all the techniques that we have right now for making better thoracic kyphosis. And in our institute, we are using in situ traction box, which is called the correction box. With the use of that, we can assess if the intraoperatively, before making an incision, how much flexibility can you achieve in a patient. And if the patient is relatively mild, then we can do a coplanar or rod reducer, which is concave side reduction only with single rod reduction system. If the curve is rigid and more hypokyphotic, we would sometimes use VATS for anterior release, and then 2-rod construct, which would be the simultaneous translation on 2 rods technique, or even dual differential correction by MISA, 2 rail rods in some cases, or dual coplanar system. This is the correction box that we use while in situ traction for patients. It gives a jump before we make any incision. So it gives us a good idea of how flexibility can we achieve during the correction maneuver. And we also look at the T1 tilt when we do this traction and see how much where do we want to end the upper instrumented vertebra in order to control the shoulder balance. And then this is the vertebral coplanar alignment, which Dr. Wong mentioned about having a spacer between the screws in order to correct the thoracic kyphosis and also to reduce the rib hump. This can be achieved, which is a good match with the coplanar method. So we do everything and we do the coplanar maneuver. I'm taking out the spacers right now in order so that you can see that the vertebral body is rotating while doing the coplanar maneuver here. So having this in place, the correction is maintained by the single rod, which has made contour on the concavity. So this is a single rod convexity correction holding by concave side. You can still do a rod rotation maneuver after the insertion of the single rod system, which is very simple and very fast and easy to apply for beginners as well. A rod reducer is a similar system, but it still needs, it has a stress on these temporary rods that you have to put in like this. So for rigid curves, then I would sometimes use the VAT system for anterior release, and then do the posterior releases, and then do a simultaneous translation maneuver with two rods simultaneously at the same time. And then do the translation maneuvers. Pull up the vertebral body to the two rods at the same time. You can still do a DVR-like maneuver like this, and then obtain a thoracic kyphosis. Dual differential correction by MESA is also another option. It's a single rod rotational correction system. It's a little bit cumbersome as well. And then recently we adopted the dual coplanar by using the Reline 3D by the company Nuvasive. This finalizes what we can do in 3D using the coplanar and also the dual rod constructs. You place the two rods ready in place. You press down on the concave side first for the main thoracic curves, and then go down, press down on the lumbar curve right on the left-hand top simultaneously. So you get a 80% correction by just doing this two rods going down as a coplanar method. We still have the spacers in for grading lordosis and kyphosis. And then we screw down everything, adopting the similar approach of the simultaneous dual rod correction maneuvers. And then we can use a DVR system to correct this. So vertebral coplanar alignment is really popular now in Japan. It can be applied to lumbar curves as well, like the 5C, because we are placing a very large force on the rotation because of this tower pressing down on the rotation of the lumbar curves. It has a large force on the rotated vertebra and then the assistant holds that and then put the rod in place. So I would like to stop there. These are the current concepts and techniques that are applied in the correction maneuvers, and happy to take any questions if there are any. Thank you.
Thank you. Great presentations. Because of time limit, we have only one questions. Do you have any questions?
Excellent technique, Sergey. Can I just ask you, I also do coplanar simultaneous reduction. How would you insert your reducer? Do you insert concurrently both sides, or you do lumbar one side, thoracic the other side? What's the sequence that you do?
So now we can place the rods. Before, the system didn't have that, where you cannot put the rod inside the coplanar instrument. But now if you use a MIS treatment instruments that has slots all the way down to the screws, so that you can actually use the final rod to do the coplanar maneuver. So which is that we use that so we can place reducers in both sides and do the manipulation, coplanar manipulation on the main thoracic concavity, and then do a maneuver on the lumbar concavity simultaneously.
Thanks, Dr. Sakai, and thank you for all participating speakers on great presentations. And please, Dr. Wang, conclude and summarize this webinar.
Well, I think it's been a great 2 hours, 2.5 hours or so. And, I'd like to thank all the speakers, the moderators, and the online committee for this wonderful session. Some of you will see the increasing complexity, from a simpler correction of scoliosis to the final event when you have a lot of metal work. But don't be discouraged, because what you are doing now may still be very good, and it's up to the newer generation of surgeons with these very complicated implants to show that they're better than the simpler one you are using. So the result's not out yet, okay? So don't give up, and don't think that we need to have very complex instrumentation as yet until something is proven. But I think that all illustrates good concepts, right? In that the correction of scoliosis is a three-dimensional correction. Three-dimensional correction of not just a coronal correction, but a sagittal and rotational correction. The cases also illustrate, even in the coronal correction, a need to maintain balance. If you correct the main curve very well, you have to think about the other adjacent curves, whether they'll go out of alignment, whether your shoulder will get out of place or tilted too much, or whether the whole trunk will be shifted. And of course, even going even more further back to smaller curves, there are non-fusion alternatives available now. But even then, that's not all proven, and case selection is still very important. So it looks like there's still a lot of exciting things happening in AIS surgery, lots and lots of progress, right? So I'm just would have been better if there are some questions or from the audience, but unfortunately we didn't seem to have obtained any questions. Hopefully for a future seminar we will be able to get that. Okay, with that I would like to call this webinar to an end. Thank you very much, and good evening to everyone.
Thank you.
Thank you very much. Good evening.
Thank you.